here.
All right.
Scott, that's not Baltimore behind you. I know that town well.
Yeah, no, it's Italy, like 20 plus years ago when I actually was able to travel outside of meetings.
This is the Amalfi Coast.
Correct. Yep.
So Tyler, you want to go ahead and share your screen?
Absolutely. First question, how do I do that?
So
wait, open share.
Yep.
There we go. Okay.
And by the way of introduction, hi Tyler, we're delighted to have you.
Hi.
None of us bite. We're all really nice and just like you are. So delighted to have you do this.
Reassuring. Appreciate it. So my name's Tyler Smith. I'm at NYU, and we'll get started with this case. He's actually, well, of course, he's an interesting case. So he's a 45-year-old gentleman. He originally came to our center back in 2018, but he'd been seen by multiple other physicians for years before. 45-year-old African-American gentleman. Around 10 years old in 1985, he had an episode of limping for 1 week, unclear cause.
Tyler, sorry to interject. If you're advancing the slides, we can't see that, or at least I can't see it.
Oh, you can't see it?
Does it need to be on slideshow? Because at least on my screen, it's very small. And I can see
what can you
on the left.
See?
Yeah, if you go to bottom right of.
Yeah, you have the presenter's view with all your other slides. You want to go to slideshow, I think.
Yeah.
So
what can you see now? Can you see the slide that says HPI and a list of?
Yeah, it's small text for the old farts in the group. It's we need a little.
So I'll explain. Nope, it's okay, Tyler. I'll tell you guys how to make it bigger on your individual screens. Tyler, we tested putting you in having it be in presenter mode, and there was something glitchy that was going on, right?
Right. And so I don't think I'm doing that.
That's fine. Don't worry about it. So here's what I want everybody else to do. On your mouse, on your keyboard, you want to hit the control button and then have your mouse, your cursor actually on Teams in the slide. And if you do that and move the wheel on your mouse, you can blow up your own individual view. You can make it bigger, you can make it smaller. So you hit control on your keyboard and then the wheelie mouse, you want to make sure that your cursor is on the window and then hit the scrolling wheel on your mouse and it should zoom in for you.
Uh-oh.
I think I'll stay with small. I'm afraid of erasing it.
Okay.
Yeah.
Well,
all right, Tyler. Go ahead.
I'm hitting control.
Tyler will read it to us older folks, Elliot.
Okay. All right. Thank you.
Here, maybe I can.
Well, I have control.
There.
Doris, I'm just wondering which other icon do I hit? Because I don't have a wheel. I have a flat panel, a Mac. So if I
wouldn't worry about it, Tyler. This is just like you're presenting on rounds.
Yeah, you know what, Tyler? You're the boss of this presentation. Just tell the faculty, guys, just stop it. Just go close to the screen if you need more power. This is my presentation. You guys are done. Figure it out.
Where's Galetta? I need a refraction.
He's there. He's there.
I'm hiding.
Okay, sorry. Keep going. We'll stop interrupting.
It's okay. So in 1999, he had this altered sensation in his bilateral ankles, feet, and hands. Again, unexplained cause. In 2000, he started developing progressive right-sided hearing loss. And then in 2001 to 2002, it spread to the left side. And again, it was this progressive course. In 2002, he was diagnosed with MS and initially started on Avonex. And basically through 2013, he progressed to using Betaseron and then Tecfidera in 2013. Between 2010 and 2017, he would have these episodes of what he described as bilateral blurry vision, relatively quick onset, would last for about a month before self-resolving. He'd also have these episodes of unsteadiness or vertigo, again, pretty quick onset, and would last about a month before resolving. At least for one of these vertiginous episodes, he really received 3 days of IV methylprednisone. Balance initially worsened after it for about a week, and then it resolved. In 2016, he had a cochlear implant placed.
Is that on the left?
That was on the right side.
On the right side, okay.
Yeah.
And can I ask you, when you said progressive right-sided hearing loss, progressive over what period of time? Weeks or months or years? Or
I believe it was over the course of months, but it wasn't entirely clear from the records.
Okay, thank you.
And filling in a little bit more history on him, he has this history of hypertension, sickle cell trait, and of course, this hearing loss. Between 1998 and 2008, he was using significant amounts of cocaine, heroin, alcohol, cannabis, and cigarettes. He was working as a DJ during that time. Family medical history, notable for cancer in his brain cancer in his brother and lung cancer in his mother. We don't have any other types of information on those, however. As far as his initial exam goes in 2018, visual
Tyler, the slides are not advancing at all.
I think you're on slide 4, but we're still seeing slide.
Oh, really?
There we go. That's now it's going.
There we go.
That's interesting because I see the next slide. Well, just let me. I don't know.
We're
just
on slide 3
figure it
right
out.
now. Yeah.
Do you see a history and initial exam?
Yep.
Okay. Good. So his notable exam findings: visual acuity was 20/20 bilaterally, constricted visual fields to confrontation. Hearing was intact to finger rub on the right, which is where he has his implant, and absent on the left. Strength was 5 out of 5, and reflexes were 2+. When asked about his hearing loss with a little bit more detail at this point, he said that it was always attributed to his work as a DJ, where he'd had, they thought it was related to listening to loud music for years. So I want to pause here and see any thoughts. Does everybody, any thoughts about this diagnosis of MS? Any red flags? What kind of differential are y'all thinking about at this point, just based on the history in a brief exam alone?
Yeah, let's, so I'm going to be moderating this, so we didn't say that from the beginning.
Okay.
So why don't we do like we've done previous webinars, where we start with the fellows, and feel free to be vocal, and then if there's any additional questions from the faculty, we'll have that. So fellows, what do you think about the history? And to Tyler's question, which I think will be nice to go through, are there any red flags to the case that would maybe point you in a different direction than MS? Obviously, we haven't seen the imaging yet, so that also helps, I think, when you're developing a differential.
Yeah.
But what about the history?
I would think that early hearing loss, you might be concerned for something like Susak's, or I think Behçet's can cause hearing loss too. So I would be concerned about those things potentially.
Yeah, very good. Yeah, because in MS.
This is Danielle.
Go ahead, Danielle.
Oh, hello. Yeah, so I was just thinking that perhaps the sudden onset of his symptoms and episodes are a bit concerning. I would also think of potentially vascular etiology, something hereditary. It started when he was very young, and also the fact that the course has been progressive without kind of full recovery in between his episodes is a bit suspicious. And of course, children have MS, but he hasn't, I wouldn't expect necessarily hearing loss to be one of his presenting symptoms, especially bilateral. That's a little bit strange. And yeah, I think that's.
Very good. Any other fellows? What about the sort of social history? We've had other webinars where we've talked about substance abuse and potentially neurological complications of that, which could be quite, wide. Okay.
Dr. Scott's point is well taken, right? I mean, he's got multiple substance abuse.
Yeah. Are we moving on to faculty participation yet?
I thought I heard maybe a fellow interject.
Oh, yeah. So I was going to say that I would be concerned for like a white matter kind of abnormalities from substance abuse, especially with something like inhalants. Generally, you may have more of an encephalopathy kind of presentation, but I'd still be concerned with that.
Yeah,
I agree
absolutely.
with that. It's just I agree that definitely something like chasing the dragon needs to be considered. I think it is also important to keep in mind that it seems like his episode started before he started using illicit substances. So it might be aggravated by illicit substance use later on.
Of course, you never know, right? I mean, we like to trust our patients when they're providing a
Right.
history, but we have to be very cautious with, these defined time points, 10 years of substance abuse, and, err on the side of caution. But I
True.
do like putting that in, because we certainly have seen for these toxic leukoencephalopathies from cocaine and heroin abuse.
And
Yeah.
if you're worried about vascular, especially somebody who's a sickle trait, I mean, cocaine it causes encourages vascular lesions, strokes, and bleeds. I don't say that that's what this is. It'd be nice if we knew a little more about how that hearing loss progressed and what his audiometry showed and what his bears showed, because I wouldn't think, I mean, again, somebody pointed out bilateral would be distinctly unusual. And the ones I've seen are sort of, over weeks. They're not over multiple months. I wouldn't think if you had, I mean, if it got better on its own with a relapse, it got better on its own with or without steroids. But I wouldn't know that, I guess I don't know whether a cochlear implant would do you much good with a central lesion.
I think I'd point out that if the bilaterality was in close proximity, one of our fellows from last year, Alex Cruz, and our medical student, you guys may have remembered, they presented this palinacusis case where there was sound and turned it off. It was perseveration like palinopsia. But in the context of writing that, we were invited to produce a review on hearing loss in MS, which is pretty unusual, but to have a singular lesion causing bilateral loss within the same temporal frame, the one place you can do that is the trapezoid body with the crossing patterns of the acoustic stria. Of course, you can have multiple lesions and do it, and we report on 4 of these cases that are just like this, but pretty unusual. So the other things that would come to mind for me, and I think it dovetails well with the substance or toxin exposure, and that is there a double hit here? Does somebody who has an underlying predilection, maybe a mitochondrial cytopathy, and as we know, alcohol, certain drugs combined with that predilection can lower the threshold for neurologic deficits. So the things I would think about, I would want to know in a young guy, first of all, and I know Jen is here, so I got the pediatric representation. Did this guy have a careful enough ophthalmologic exam? Is there any evidence that there is, for example, any features of pigmentary retinopathy? Because with hearing loss, then that would raise some other differentials like Alstrom's and Usher's disease, and he doesn't have the phenotype of Lawrence Moon Beetle, but one of which we can look for is Revson's disease with excessive phytanic acid. And in a guy with hearing loss, I wouldn't want to miss that. So for me, I would want to make sure I looked at mitochondrial cytopathies, look at Revson's and phytanic acid, and probably, given the age, I'd probably run amino and organic acids to look for any of the acidurias. In abrupt hearing loss, we do have this condition, which is inner ear autoimmune disease, used to be called the 68 kilodalton inner ear antigen antibody. I think it's now been changed to heat shock protein 70. And I've had a number of people with acute or subacute who have these antibodies. They're repeated, they're high titer, and the presence of that, I think, would provoke or compel you to think broadly. Jen and Scott were talking before we started about identification of medications that would cover multiple conditions. And in these cases, that's exactly what we've done in those circumstances. So we have seen those.
We've seen sarcoid occasionally, rarely, actually.
And because of bilateral, right, I would want to add, got to look for a basilar meningitis. Is this both cranial nerves? There are others, there's vertigo. So absolutely, your point is well taken. Don't get it out of the brainstem, get into the basilar meningitic compartment and ask the question, do we have leptomeningeal carcinomatosis? Do we have granulomatous inflammation? Do we have a viral process? Do we have Malloy-Ray's coming and going? So I think your point is a great one.
With the length of this process, I would think carcinomatosis, even treated, he wouldn't still be alive, but sarcoid.
That's correct.
Is still in there.
And I want to ask Andrew Goodman, put him on the spot, just going back to what are the red flags within the sort of history and exam. The magnitude of the hearing loss, I think, is really critical in these cases, at least from what I've seen. MS causing the severity of the hearing loss is, well, what do you think about that?
Yeah, so I agree. I don't think I've seen that that I could directly attribute to MS. I guess I would also agree with, I can't remember who it was, Daniela, who was concerned about vascular process. I mean, he clearly has a number of vascular risk factors: hypertension, cigarette smoking, cocaine use, and God knows what else, and sickle cell trait. All.
And the exposure point is also important in terms of, do we know that he's had any antecedent exposure, for example, to aminoglycoside, antibiotics?
Good point.
Some genetic mutations have indicated you can have both, loss of cell and stereocilia for either the acoustic or for the vestibular stria. So I would bring that up. And then lastly, this is so peculiar. I agree with Scott. Is there a family history here? Is there potentially something like otosclerosis, which is a dominant incomplete penetrance, scarring, cochlear involvement, can be precocious in life, and not everybody has it, but is there a family history of somebody who may have not the same magnitude of this guy, but it has some penetrance? So otosclerosis shouldn't be forgotten in the same way you think about mitochondria and say, yeah, I mean, I'm with Andrew with this one, by the way. We've seen it with MS, but it's very rare to have this, especially bilateral. And Doris, I'm going to share the review that Alex and the med student and myself and Teresa put together. We used 4 cases. I'm going to send it to you guys. These were all confirmed MS, including one in the trapezoid body that was an absolutely spectacular lesion. Alex was holding up the audiograms, and I was looking from behind, and I could see both bilateral, simultaneous, and then I won't say who the neuroradiologist was, self-proclaimed, but he missed it. He didn't see the coronal with T1, and it's a circular lesion that extends right into the trapezoid. And our artist, of course, Scott, made a beautiful rendition of these various spots where it did turn out to be MS, but it wasn't like this, like, precocious bilateral. I mean, this is, I think that Tyler.
And it wasn't this, Scott, just to be clear. I'm not an artist. I wish I was. But...
No, I know. But Tyler, a fellow, you did a great job underscoring that this is something unusual.
Yep. He's a relatively young guy. You don't want to give him 2 diagnoses if you don't have to. So you'd have to ignore a lot of the symptoms that are not referable to the statoacoustic nerve and its connection. So, he could have 2 things. And somebody said he could have an underlying mitochondrial something, and his, it sounds like his history of abuse is, some of the patients will say, if I could get a hold of it, I used it. And that's what this sounds like.
So why don't we have Tyler take us through, because I think there's some MRIs that could help branch out the differential a little bit.
Scott, may I just make a comment about the visual fields?
Sure.
Because you focused a lot on the hearing, but the visual fields are a red flag, right? Because they're constricted and they're not central scotomas as one might expect, right? So what do you think about with constricted visual fields? In this case, you can think about glaucoma. Now, how do you get glaucoma here? You could get it, as been suggested, by a ischemic mechanism. New vessels can form in the trabecular meshwork and you don't drain, and therefore you lose your vision in a constricted visual field. You could have what Elliot suggested, which would be, is this some sort of retinitis pigmentosa, either typical or atypical, right? If it's atypical, it can be mitochondrial, where it's more of a salt and pepper type of change rather than the bone spicules of typical retinitis pigmentosa. You would think about papilledema. Again, papilledema tends to constrict the field with preserved visual acuity. You could think of conversion disorder, unlikely here. An unusual one that I've seen once or twice is that you infarct the central retinal artery, but you have a cilioretinal vessel that comes off the choroidal circulation that supplies the macula. And in that case, you get a constricted field, and you're very lucky that 20% of us have a cilial retinal vessel that supplies the macula separate from the central retinal artery. So you can get constricted visual fields from a vascular occlusion to the eye, and it may in fact be bilateral, particularly if it's systemic.
So
I
Steve,
just offered some of those possibilities for the constricted fields.
Steve, have you seen that with sickle cell disease?
I personally have, sickle cell can cause peripheral retinal ischemia. That's what it classically does, is that it occludes the peripheral vessels. And you can get all sorts of unusual findings like AV anastomoses, you could get little hemorrhages out there. But yes, it could conceivably be related to sickle cell disease.
And one other area, Steve, to your point, is the relative or the component of protection in somebody, for example, with visual system giant cell arteritis, where that hook bundle or that hook vessel that you're talking about is relative. It's somewhat protective in those cases. So when you see it, reflects the contribution from that other circulation, you feel better about it. But as you know, there's a distribution of outcomes in those cases. So maybe.
Yeah, no, I think that was great to bring up, Steve. Just in the interest of time, and I didn't mean to bypass the neuro-ophthalmological part of this, which I'm sure we're going to have more dialogue later in the case. But Tyler, why don't you take us through, because I think the imaging will be coming up soon.
Sure.
Okay.
Yeah, so this is the MRI that we had in 2018 that he brought with him. And we can go through this more in the MRI section. Maybe we should do that just for time, and we can talk about some of these are some of the differential diagnoses that we came up with. Trying to lump all his.
You got to advance. Sorry, Tyler, you have to advance the slide.
Okay. For some reason, when I do this.
We go.
There we go. We can see it.
Okay. All I'm doing is closing it and opening it up again, but I'm glad it works. So we tried to.
He didn't have a forelock of poliosis, of hair depigmentation like you might see in Voit Koyanagi Harada. He didn't like color his hair or anything, did he?
Nobody documented that. It would have been really neat though. I've never seen it. It would have been cool. But yeah, so we were trying to think of brain, eye, ear syndromes. And so we came up with Susak's, deficiency of adenosine deaminase 2, Kogan's, Eel's, Behçet's, Sjogren's, sarcoid, and Voit Koyanagi Harada. We didn't think of the mitochondrial diseases, but that was a really good thought as well. In terms of some basic labs here, hemoglobin was 14.3, ANCA, proteinase 3 antibodies were negative, ACE was less than 5, syphilis was negative with RPR, HTLV was negative, ANA was slightly elevated at 80, double-stranded DNA was negative, cardiolipin, beta-2 glycoprotein were negative, ESR and CRP were normal, SSA, SSB were negative, and its adenosine deaminase level was normal. His heat shock protein, IgG, was positive. I don't have a titer on that. And his NMO and MOG were negative.
Tyler, can you just stop for 1 second? Is that the HSP70 that we were talking about that used to be the 68 kilodalton for the inner ear antigen antibody, or is that something else? The heat shock protein IgG?
I believe that's the HSP70.
Okay, that's what I thought. Okay, thanks.
And the NMO and MOG were cell-based assay?
Yes. And they were both negative. As far as other studies go, we have a couple CSF samples. One is reported from 2000. We don't have confirmation from that, but it was reportedly normal with normal cells, normal protein, and no bands. 2018, we repeated it. 1 white cell, glucose and protein were fine. 0 oligoclonal bands, normal IgG index, VDRL, HTLV, ACE, non-reactive or negative. We have some visually evoked potentials with a slightly prolonged P100 on the right compared to the left. And I believe the normal for this one was 94. Yeah, it was 94. And so that's where we are in terms of our other studies. Are we ready to go to the MRIs?
Yep.
Okay. So I tried to pull up some just to kind of show change over time. And so on the left, we have is 2010 MRIs, and on the right, we have some that were repeated later in 2020. And for the most part, they show some stability. The areas where we saw a slight bit of change was over here, kind of extending into the right frontal lobe. I don't know if y'all can see my mouse, but this T2 hyperintensity was slightly expanded compared to 2010, but for the most part, it was pretty stable. We have here we're just looking at the sagittal views. We do have some.
I'm sorry, do you think that there, on the 2020 film, that there is evidence across the four, if you look at it, it's consistent, that there's sulcal widening, suggesting that there's some gyral atrophy? And I know they're not exactly positioned, but the general sense is, you know, they're not as tight as they were in 2010.
Yeah.
I agree, yeah.
Yeah.
Not horrific, but I think, you know, demonstrable.
Yeah.
Especially more posteriorly. If you look there, it does really hit you, doesn't it? Yeah.
Yeah.
Right there. Yes. That's a really good thought. And then these are from 2019. And what I was really trying to show here is whether or not we think he has any Dawson's fingers. He does have some lesions extending here, but they're not exactly the broad base that we would typically think to
Hi,
look.
Tyler. Sorry to interject again. I don't think we see it.
We're still there. We go.
Oh, there we go. Yep.
Thank you.
How's that?
Well, a number of these seem to emanate from the subependymal zone of the ventricle coming up. So I would say they would meet that criteria, not necessarily absolute specificity, but these to me look like they're ependymally based extending up. So these would qualify.
Then here's just another set, kind of looking at the same thing as we had across. And then here's where we can see some changes over time, taking selected cuts. So in 2016, he had interval development of this new left pontine lesion, non-enhancing, no restriction. In 2017 and 2018, we noticed that there was this periatrial lesion that was enhancing, no restriction. And again, it was enhancing here in 2018 and perhaps encompassing a little bit more area over here that wasn't seen in 2017.
By the way, in 2016, does that scan correspond to any particular clinical semiology? For example, was he having, let's say, subacute evolution of bilateral hearing loss during that time, or is this already too late in terms of his earlier hearing loss?
To his recollection, he doesn't recall any symptoms associated with these events. The hearing loss had mainly been in 2001, 2002, 2003. I don't think he reported any progression after that point.
Okay, got it. Thanks.
And then let's go to the next slide over here. And so in late 2019, one of our radiologists noted that they couldn't clearly see the normal signal in the bilateral semicircular canals, and they thought that this was related to labyrinthitis ossificans. So that's what I'm showing here in this slide.
And just for the fellows, what about the lesions in the cerebellum? What do those sort of look like in appearance?
Those have been there for a long time. To me, I was a little suspicious of perhaps a vascular cause.
Yeah, they sort of they look like it, right?
Mm-hmm.
Tyler, how do they look on T1, these lesions? Did they look hypo-intent? Sorry, on a flare?
The posterior lesions, in the cerebellum.
Did they look hypo-intense or hyper-intense?
I think they were hypo-intense.
Hypo.
Yeah.
Which actually also goes more with something like lacunar strokes.
Certainly vascular. Yeah.
So again, thinking about red flags, right? I think this is another one that I would check off as a red flag for not MS.
Yeah. And then we'll go here to our next slide. So on the left, we have, he had multiple spinal MRIs, all of which have been normal. And I believe this was his third or fourth MRI of the brain, all of which have been normal. And so I thought this might be a good place to stop and kind of get everybody's thoughts. We've talked about a lot of red flags. And what else, what other studies would be useful? What else do you think would be kind of guide our decision making and looking at our differential?
Did anybody look for CSF lactate?
Yeah,
I
that
don't
was
think-
one of the questions
no.
we had. Right.
And has anybody done MRS?
Well,
on
let's start with the fellows first. I know it's easy to jump in, but let's hear from the fellows and see what other sort of diagnostic studies would they want to see that may be readily available. Some of these more novel imaging techniques are tough to get even at larger institutions. So I see Sarah is on, Sarah Conway.
Hey, can you hear me?
Yep.
I think it's still pretty broad in my mind. I'm wondering about sending almost like a leukodystrophy panel looking for genetic causes that could tie all of these things together. That was one thought. The second thought would be to do more neuro-ophthalmologic imaging. Like, I don't know if a fluorescein angiogram or something like that could help lead to diagnoses. But those were my two thoughts.
Yeah, I think going back to what Dr. Galetta had mentioned with the constricted, view in some of the differentials that he rattled off from a vascular perspective, fluorescein angiogram definitely is something that I think a lot of us would consider. No, very good. What about other fellows? And then maybe I see Dr. Balser's on. Maybe we can get her expertise.
This is Ryan with Rochester. We could always do an MRI looking for a central vein sign to see if we can help distinguish whether some of the periventricular lesions are vascular in etiology or related to MS.
Yeah, and there's sort of a newer technique, also black blood imaging, that I think a lot of institutions are starting to use to look for vasculopathies in the setting of if you're going to try to target for a biopsy, especially in what we think are small to medium-sized vasculitis, where you're not necessarily going to see on MRA or even conventional angiogram abnormalities. Yeah, that's great. So, Dr. Balser, not to put you on the spot, but I saw you and I was very excited.
Yeah, I'm sorry and not sorry that my video doesn't work on this platform, but the basically sometimes the OCT that's of the macular region can reveal retinal abnormalities that are more consistent with a vascular process. We reported a case that was Susac syndrome several months ago, maybe it was a couple of years ago, but basically with a great OCT imager, such as Rachel Kenny, our grad student, you can figure that out. So that may be another thing to add to the mix of tests that the patients already had.
And is there a specific OCT machine? Are you talking the Series, the Spectralis? Because I know the vessel imaging that you can see sometimes is a little more robust.
Yeah, it's either, but it's really the pattern in the macular, what's called the retinal image. So it depends on the platform, as you point out, but really looking at the pattern within that macular region of 30 degrees can be very helpful.
Is there a reason why we're not telescoping a bit, knowing we've got a positive heat shock protein 70, which can foment inner ear inflammatory and autoimmune disease, and we've got a bone diagnosis of labyrinthitis ossificans? And I'm wondering what the relationship is, Tyler, if you looked at this, the relationship between ossificans and that autosomal dominant with incomplete penetrance disorder of otosclerosis. And maybe a part of that, that damage and organization and exuberant bone growth of the otosclerosis may be related to this inflammatory or autoimmune state in the inner ears.
So I didn't specifically look at that, but I thought that the heat shock protein had kind of low specificity. And I think it was thought that it would be kind of unreliable to hang this whole diagnosis that would explain everything, including the rest of his brain MRI on that alone.
Yeah, Yeah, I don't think I would hang the whole, but I mean, if you've had that, you've repeated it, this is a process we've seen before.
Mhm.
And yeah, the question is, does it compel you to think about specific treatments in response to having that and having radiographic evidence of damage? One of the things you could do would be ultra thin cut CT to really further define this. But it sounds like the radiologists have already made the call about ossificans and that heaped up fibrosis and damage that's going on in the inner ear. Another reason why, again, I would want to know about other family members who may have maybe a less exciting experience because maybe they haven't, on top of that, used all these illicit drugs of abuse, which could have, unmasked a bigger syndrome than it might have been without it.
The heat shock protein elevation, about the antibody too, but the heat shock protein elevation is a very common inflammatory response. You can induce it with cytokines and tissue cultures. The gene goes up within hours, and other genes go up with it, including some that have to do BEST protein and several others that have to do with calcium and ossification. But and probably not the heat shock protein in those cases. There's something called osteoprotegrin, which is in the TNF alpha receptor superfamily and so forth. So the heat shock protein, I would agree with Tyler. I don't know that it's super specific. The more you look,
just to piggyback off of Elliot for a minute, I think when you have a positive test, especially in a rare syndrome like we're seeing, it's always good to consider what are the pieces that could add to the development of a diagnosis or a clinical syndrome. And so, but let me just give it back to Tyler so you can take us through. I want to be sensitive to the time and get others a chance to talk.
Sure. So the next thing we did actually was fluorescein angiography. I've got a photo of it here. And I just was looking up his retina OCT while we were talking, and it was reportedly normal, although I can't pull up the image at the moment. On his angiography, we see this area of peripheral non-perfusion over here. And the ophthalmologist was noting that this over here is evidence of CFAN neovascularization. And he said that these findings are consistent with what you might see in sickle cell disease.
So Dr. Balser, I just ask you, because I know Dr. Galetta had mentioned maybe a couple times he's seen sickle cell disease and the ophthalmological manifestations of that. How about yourself?
Yeah, I haven't personally seen it, but certainly this is a humbling condition, sickle cell disease. And so to have these findings in the retinal vasculature certainly points to the possibility in my mind.
Okay, can you hear me? This is Mila.
Is this Dr. Goldman?
Yes, okay,
wonderful to hear your voice.
I've been trying to ask a question for like the last 30 minutes, but the mic on my computer in the clinic was not working, so I called in. This is my question, and I apologize if you've covered this in my fiasco to become part of this conversation. Laura or Steve, Dr. Galetta or Dr. Balser, could you speak to that visual field presentation and how and if it's discriminating in this case between Susak's and this sickle cell presentation? Because I always would think Susak's with the vision and the hearing, and I know that was on the list of the differential, but did the field help us in this case, or only do we need the angiogram?
I'm going to defer to Steve as always if he's available, but I think that really both disorders could lead to branch retinal artery occlusions. And that's the thing we have to keep in mind here. And that's the thing that actually a conventional OCT, of the macula brought to light in a case of Susak's. And so often it's a team effort with regard to people and with regard to devices that we use. And if you can go back to the original visual fields, are they just generally constricted, or how would you describe them, Tyler? You're doing a great job.
I wasn't able to pull them up for some reason in the procedures tab.
I see.
But everywhere it says that they were just peripheral constriction throughout.
Yeah. Visual field is a hard test for most patients. And so sometimes that can be a tough call. And yet the patterns on the OCT with with an experienced imager, and the presence of vasculature occlusion, as we're seeing here in these photographs, really points to something other than MS, in my opinion.
I was going to follow up
Thank
and
you.
say, now that you have the fluorescein angiogram, were the visual fields truly 360 degrees constricted? If you go back and look at them, was it a true kind of global constriction, or was it more just specific peripheral loss?
I agree. That's a big question, and visual fields are tough. They're tough for the patient, tough for the examiner, and so I wouldn't be surprised if this patient had a defect that was disconnected from the blind spot. And that is something that we look for a retinal disorder, be it vascular or otherwise. Great point.
Any relationship that you might see in this case, given the conspiguity of the inner ear, thinking about sickle cell and osteopontin and knowing about its regulation at the osteoblast level and getting this fibrosis and bony overgrowth. So is that something that is fruitful to look at in these cases? We used to talk a lot about osteopontin and then hear a lot about it. I don't know, maybe Laura fired it out of a cannon. There's a lot of interest in this particular.
Oh, that's a lot. That's a lot. I mean, it's what we see in Susak's, the hearing loss, you got the retinal things, but here's a patient with sickle cell, and we have to be humbled and looking for that as an etiology for any of these neurological deficits.
Totally agree.
So Tyler, why don't you?
That's why you presented to Tyler.
Move through and
doing great, Tyler.
So we all like the thought of sickle cell, but the problem is he didn't have any history of pain crises, chest pain, or anything like that to necessarily fit with it. But when we sent him for hemoglobin testing, he came back positive for hemoglobin S and hemoglobin C. So not your classic sickle cell disease, that's hemoglobin SS. A little bit different. And reading through this, it sounds like it's generally thought to have a generally more mild severity, lower frequency than your typical sickle cell disease.
Unless you're a bad boy.
Yes. And so, but
not great because he's not SA.
What's that?
SA. Earlier it was implied that he was SA, wasn't it?
Yes. Yeah, that's by his history.
But the SC and being a bad boy, as Dr. Roman put it, could be involved here. And vascular and other things can raise your heat shock protein as well.
Mm-hmm. Absolutely. So the occlusive retinopathy, the rosary pattern on a white matter injury, the labyrinthitis, ossificans can all be seen in hemoglobin SC disease. In this series, about I think 179 patients, 29% were diagnosed after 18 years old, 30 to 70% were experiencing retinopathy, 29% otologic disorders, and 2% were experiencing stroke. And when we tried to reconcile that with what seems like a larger vascular burden than we would expect for this, we were wondering if maybe the use of the vasoconstricting substances like cocaine and so forth may have, in combination with the hemoglobin SC disease, maybe that caused to have this high vascular burden. That for years, everybody was thinking was MS, but it was actually related to cocaine use and sickle cell disease. Maybe that's why between 2010 and 2020, there was relatively few new lesions as compared to the years prior, which we can only infer because we don't have images prior to 2010 or 11.
No, but clinically, right? In terms of his history, you could somewhat infer that. And I think, I don't know if you're going to talk about treatments, but there was a recent monoclonal antibody that was approved for use in sickle cell disease, which is, from my understanding, a game changer in terms of the crises that people experience. And so it goes beyond just, transfusion therapy. So I'll let you, Tyler. I don't know if you're going to talk about that at all, or
just a touch, because it seems relatively limited for SC disease.
Sure.
In terms of transfusions, the efficacy is really not proven, and it's generally, when they become more anemic, but his hemoglobin has been 12 to 14 pretty consistently, and so hematology has only seen him a couple times now, but they haven't started any transfusions. Phlebotomy or hydroxycarbamide have been considered, but they haven't pursued that in this case yet either.
Are we talking about a Docvio or a different one?
Yeah. So that
All
sort
right,
of binds
sure.
P-selectin cell adhesion
Okay.
molecule. Yeah. Yeah, apparently it's really a huge game changer for the SS disease.
Vaso-occlusive crisis, yeah.
Great. Well, in interest of time, that was fantastic. Tyler, you did a great job, and thank you for the NYU mentors that are on. And this is the first that I've heard of such a thing in terms of the ever expanding sickle cell disease and the neurological complications that can come from it. So it's very, very interesting.
So for Dr. Galetta and Balser and Tyler, not that it matters, but I'm sitting here in my chair and the sweats I have on, Steve, are my NYU sweats. So
We love it. Go Purple.
Hey, that's awesome. Yeah.
We're just glad you're wearing
a great
pants,
job.
Dr. Lissack.
Right.
Yeah.
what was the
Tyler,
name of
great job.
CNN? We're not going to get into that one.
And thanks for everybody's support of our trainees. Thank you.
Absolutely.
All right, fantastic case. Let's get Maria's slides up. Maria Zhang is next. She is a pediatric neuroimmunology fellow at OHSU and has a challenging case to review with us. So Maria, we'll go ahead and let you jump in. She's got about 4 slides to tell us some key initial history, and then we'll stop on the 5th one for some discussion.
Okay. You guys can see the slides, okay?
Yeah.
Okay. All right, so this was a 16-year-old girl who was developmentally normal and had a history of episodic migraines for the past 6 years. Her baseline headache frequency was about 3 times a week, and she actually had a normal brain MRI from 2017 as part of her headache workup. Then in April of 2020, her headache kind of evolved into persistent daily headaches without any headache-free intervals. It was 10 out of 10 in intensity, throbbing, associated with severe photophobia, frequent nausea, vomiting, and had some red flag symptoms where it was worse when supine, bending over Valsalva, also was waking her up at night a lot. It was difficult for her to attend virtual school. She was spending most of her day really just like laying in the dark room. Then about a month after this started, she noticed new blind spots in the middle of both her eyes. Also had symptoms of transient visual obscurations. So she saw a community ophthalmologist who made the diagnosis of bilateral papilledema, although we don't actually have detailed records from that eye exam. And then the rest of her history, a lot of pertinent negatives. She really didn't have any other focal neurologic symptoms or deficits. She didn't have any history of encephalopathy or confusion, personality changes, or seizures. No recent illnesses. Of course, this was kind of the beginning of COVID. And no recent weight changes or any rheumatologic kind of symptoms on the skin or her joints, or any oral genital ulcers. She hadn't been on any acne medication or OCPs. No known, she denied any sort of substance use, and no recent travel. And she had really unremarkable birth and development. She was getting A's and B's in school, and past history was just notable for episodic migraine plus anxiety, and she was on an SSRI and sumatriptan PRN. So she saw a neurologist virtually, and they got an MRI of her brain, and there's some artifact in the puns here. But supratentorially, they found kind of this new interval as of 2017, kind of periventricular central white matter and subcortical white matter, T2 flare changes. There was bilateral, confluent, kind of near symmetric. Read it one more time. There's also a little bit of kind of effacement of the sulci, as well as protuberant optic discs, dilated optic nerve sheath. Her MRV did not show any evidence of thrombosis, although there was some right transverse sinus stenosis.
Maria, did you mention the patient's body habitus in terms of?
She had a normal BMI. Yeah, good question.
And there hadn't been a delta, a big change in BMI over the preceding.
No.
Okay, got it. Okay.
And Maria, was there any, because it was hard to see as it went by, but once you got lower down, it didn't seem to have any of that track effect that you would see with some of the leukodystrophies, although they don't have to have them.
Right.
Sometimes they're better seen on the sagittal than the coronals.
Could we see that again, by the way? That went by pretty fast. Can you point that out, Bob?
I didn't see one. That's what we're used to seeing with the leukodystrophies.
Yeah, location. I think I just missed it.
Yeah, and I didn't see any, except for that artifact that Maria pointed out in the pond. You don't see that tracking effect that we often see with the long-standing leukodystrophies, because the flattening of the globe and the optic sheath enlargement, the lack of sulfide, but this kind of diffuse white matter, not very dark, and but there's no tracking effect that I could see. Sometimes you can see it all the way down through the medullary pyramids, and it's not here, and not in this case. The lack of it that I've noticed.
Okay.
So she was essentially sent directly to the ER for an LP, which confirmed an elevated opening pressure of 33 centimeters of water, actually with also a mild pleocytosis with 7 white normal protein and glucose. And at that time, she was diagnosed with idiopathic intracranial hypertension. So do you guys agree with this diagnosis? And also what else would be on your differential?
Okay, so let's start with the fellows, maybe even some folks we haven't, heard from yet. Let's see, I think Masa, Brigitte, Taga, or anybody else who hasn't had a chance yet today.
So I think, you know, the diagnosis of IIH you have to be very, very careful with. I think number one, well, I don't know how the LP was performed, if you know, if it really, because sometimes we get these like falsely elevated readings, but also we did find, I mean, in the MRI we did see kind of these like widespread white matter lesions that, you know, I mean, kind of, I would not expect an IIH. Also, the visual findings, I mean, I understand it's she kind of had more this like central vision loss, which is atypical for IIH, because IIH would be, you know, you would expect more of the peripheral loss. The one thing that did cross my mind with these fluffy white matter lesions, and you know, the bilateral problems observed is MOG. There's some actually some cases observed with increased intracranial pressure with MOG disease. So it's something that crosses my mind, but I mean, like other demyelinating diseases, I stay in the differential. I mean, those white matter lesions seem widespread. I mean, but they didn't really have a leukodystrophic picture. So yeah, that's kind of my first thoughts. But I think just saying this is IIH, especially with her, like, doesn't seem like she has the body habitus for it. And I mean, I would be very careful with making that call.
And what do you guys as fellows think about calling an ER, or whoever saw this person, calling IIH when you've got at least a few cells in the CSF, right? The first rule of thumb when you get an LP, trying to address possible, even if the MRI had been unremarkable, she looks like she's got 7 cells, and I'm assuming that's a little bit higher than the normal, right? So always make sure you don't stop at the elevated pressure too. Right? You want to make sure that all the CSF results actually come back normal. Don't forget to check. Any other thoughts on differential from the fellows?
This is Ryan with Rochester. Just hearing headache and white matter changes, it does make me wonder maybe about a mitochondrial disease, so something else I would consider.
Like MELAS?
Yep.
Excellent point.
I think the thought about MOG AD is a very good one, given the fact that that's eminently treatable. There's, you see that's expanding, and if you have swollen brain, you get increased pressure. So, to be a little glib about it, the patient has IH, but not IIH.
Absolutely.
I think the other point that Jen made about this was a very excellent point, because it gets down to the so-called modified Dandy criteria for pseudotumor, and that is her point about when there are these outliers like cells. But imagine, not in this case, but imagine if you had this happen, the protein, was 300-400, and then you may have arachnoid villi plugging, which can lead, of course, to hydro or elevated intracranial pressure. And that would be a violation of the Dandy. Maybe you're looking at CIDP or a MUGUS or something else. So I think Jen's point about don't just take the opening pressure. You got a lot of free information you're getting there. You've got to reconcile that if it's abnormal.
Yeah, it's also the fact that the protein is normal doesn't help you is good. Occasionally, we used to see low protein and slit-like ventricles, but without swollen brain. So if you see it, it's fine. If you don't, you don't. In this case, the protein is just normal.
What's interesting is this is a very young patient. Can you remind me her age?
Oh, sorry. She's 16.
Right. Yeah. Should you see temporal horns at all in a 16-year-old? And that, raises the possibility of something, really consistent with the intracranial pressure, but certainly something structural, or that shouldn't give you white cells, but the differential is full.
Yeah. One other question you mentioned earlier in the history, certain positional issues, and you said bending down in Valsalva, and I know that occurred, but I just want to make sure that there isn't a bending down cork where we have a colloid cyst of the third ventricle that could cause these, punctuated spikes and headache and vomiting with bending down. But imaging doesn't show that. The foramen Monroe.
The third looks fine.
Yeah. Just want to make sure, because that was conspicuous in the history you provided, Maria, which is really terrific. But you got to hunt that down and say, okay, we see that, but this is not going to take you the additional steps to say this is a colloid cyst, or you've got something that's corking in and out with body position change.
Yep. All right, great discussion. Maria, do you want to take us to what your differential was?
So certainly we considered a lot of what everybody has said. First, in the kind of immune-mediated category, definitely MOG was high on our differential given her age, as well as the white matter abnormalities and the pleocytosis. And MOG has definitely, there's been some case series and case reports of elevated intracranial pressure. And other, a little more, I guess, rare diseases, so neurosarcoid and kind of lupus have also had reports of elevated intracranial pressure, but those are, I guess, a little bit less common. And then outside of the immune-mediated category, we definitely thought about genetic white matter disease. It has that leukodystrophy-like look to the white matter changes. Generally, they're less likely to be, really unlikely to be associated with increased intracranial pressure, but this has been rarely reported in adrenal leukodystrophy. Then other possibilities, so primary small CNS small vessel vasculitis has been also some case reports of increased ICP. And then finally, the toxic leukoencephalopathy because of the MRI appearance really. Again, she really didn't have any clinical signs of encephalopathy or even really any neuropsychiatric changes or cognitive impairment. She denied, all substance use, and she had no known exposure to any medications that would be associated with it, such as chemotherapy or antibiotics.
And so I may have mentioned this. Was there any enhancement on the MRI within any of those? There was not. Okay, because that sometimes can help, I think, within the differential. Just because you have neurosarcoid up there, usually lesions with neurosarcoid are persistently enhancing.
Mm-hmm.
MOGAD's a little bit different because we know there's non-enhancing lesions, often in the spinal cord, probably less so in the brain. But I just wanted to throw that in there. Sorry.
By the way, Maria, no history of acne or having been treated with potentially
No.
acne provocative agents, or she wasn't visiting and doing a rotation with the Eskimos and eating, like seal liver or whatever, and got
All of that. All of that.
She had no recent travel.
I'm sorry,
But yeah, definitely no like oral contraceptive use or any acne medications.
Thank you.
Maria, I have a quick question. Did anybody check cytology on the CSF?
Not during this one.
The reason is recently we have seen a case of very unusual pseudotumor cerebri, which turn out a blockage in the subarachnoid space, leading to increase in intracranial pressure, and the CSF was abnormal. So point out to what Dr. Graves has said is correct. The minute you see anything abnormal in the CSF, you should be looking for an alternative diagnosis.
And that the sarcoid doesn't have to be those lesions in the brain. I mean, it could that,
Sure.
and occasionally she doesn't have RA, but there have been RA, rheumatoid nodules in the meninges, including patients who weren't previously diagnosed, not 16-year-olds, and that can obstruct. And somebody mentioned that earlier too. So any obstructive, or I think Dr. Bausel talked about, arachnoid adhesions and so forth. So any inflammatory disease ought to do that. And the glucose was, quote, normal, but since she was tapped in the emergency room, dollars to donuts, there wasn't a simultaneous or 2 hour or hour and a half later blood sugar, for sure. I'm surprised.
With the current headache, would you raise the specter at any point in terms of thinking about, for example, like a recurrent Mallore's meningitis, and then linked with pseudotumor over time? And the issue here being, would you try to hunt down HSV2 or, broaden, your differential on that basis?
You could send off for it, but I don't know that the Mallore's. I've never seen a Mallore's documented that had papilledema. I may be wrong, but the ones I've seen.
I haven't either. I'm just asking because of the protracted history of the headache. Jen underscores the 7 cells. The more times you tap, you may have, some heterogeneity. You may have 20 cells, you may have 5 cells. But the question is, there's always been this idea about these so-called epithelioid Mallore's cells, and I think it's still controversial, but just raising it from the standpoint of the chronicity.
If you're thinking of it, the HSV2 PCR is the way to go, because those Mallore's cells, literally, we had a patient with that when I was a junior attending at Penn, and Nick Ganatis, who was the head of neuropathology, you literally had to drip the spinal fluid into the fixative because they were so fragile that if you just sent it to the routine lab, you would never see them.
They destroy it. Right, exactly. Right.
Maria, you said this case was during the initial part of the pandemic. Just to cover all our bases, this patient did not have any anosmia syndrome or COVID-19 concerns, because obviously we're still learning some of the neuroinflammatory complications of COVID. So just wanted to ask.
Yeah, no, and actually, we have wanted to check in like COVID antibodies, but we just weren't really doing checking those at OHSC. So I guess she wasn't able to get them, but she didn't have any COVID symptoms.
The other issue would be lung CT to actually see how much ground glass pleural-based damage do we see out in that bronchoalveolar unit, which of course can have very far-reaching effects in terms of compromised oxygen delivery. So sorry for interrupting. Go ahead, Steve.
No, I was just going to emphasize what Jen was getting at, that in COVID, you can see papilledema by 2 mechanisms. One is that you can get a venous occlusive disease, sagittal sinus thrombosis. The other way we have seen it is in the multi-system disorder that follows the infection in kids. You could get a CSF pleocytosis and have associated papilledema that way. So at least 2 mechanisms with COVID-19, either inflammation or venous thrombosis.
That's very helpful.
Very interesting.
Excellent. All right, I think you've got a few more twists and turns for us, Maria. Why don't you?
So after her LP, her headaches resolved completely for several hours and then returned. Since she was just diagnosed with IAH at the time, she was started on Diamox. And over the next several months, her headache initially was better on the Diamox, but then in July, August, worsened again to 10 out of 10, worse when laying supine, and she also developed new tinnitus. Her ophthalmology evaluation showed normal visual acuity with normal color vision bilaterally, grade 1 edema on the left and grade 1 to 2 on the right. And her visual fields, they didn't do formal visual field testing, but it was full to confrontation bilaterally, but she was still reporting kind of the central scotoma in both her eyes.
Hey, Maria, was she reporting good adherence with the Diamox, or if you talked honestly, was she really taking it, or was she having paresthesia? So,
she says she was taking it. She wasn't having any paresthesias.
Okay.
And then her repeat MRI at that time, actually, it's hard to compare because this set of MRIs didn't include a flare. So this is why it's just T2. But the radiologist did think that there was kind of worsening in the confluent white matter abnormalities. And this time they did see some enhancing lesions that were new. And I'll show pictures of the enhancement. It's pretty subtle, but the arrows are pointing to kind of these small enhancing subcortical white matter lesions. Bilaterally, there were maybe like 4 or 5 of them.
Can you enlarge that? For some reason, maybe it's on my Mac. It's teeny tiny. Does everybody?
Yeah, it's not very big. The lesions themselves are pretty small. I don't think I can enlarge that from here.
You can sort of see the one on with your arrow. It's on the one on the further to the left as we're viewing it. That one you really concentrate in on. You can see that little punctate.
Yeah, they're very small.
The center panel is harder to see, but I'll take your word it's there.
Her MRI orbit just showed kind of changes consistent with increased intracranial pressure with the flattening of the optic nerve head and no evidence of optic neuritis. And we got a MRI total spine and that was normal.
Quick question on the MRI. Can you confirm that those areas actually had a T2 correlate when you looked at the T2 weighted imaging, that there was a discrete lesion where you see that enhancement?
Mm-hmm.
Oh, with enhancing lesions?
Right.
Yeah, good question.
On FLAIR or T2 weighted imaging, did you have did you have
to kind of confirm?
Yeah.
Flare, Maria said, which is unfortunate.
Yeah, we don't have a flare.
The other thing to that point is the pre-contrast T1. If there's hyperintensity, then you can say it's not contrast enhancing. It could be calcification or other things that can cause sort of bright signal. That's another sort of thing to think about.
Yeah, I think there are some, but I don't. Yeah, I'll have to go like slide by.
Those are not great.
Trying to use photographic memory, it looks like there are T2 in at least 2 of those 3 areas when you flip through it.
I agree,
good.
Dr. Gray. Yeah, but that's helpful, I think, for folks to remember,
And Maria, how many times was she tapped, and what was the highest protein that was recorded?
Yeah, so we ended up tapping her like 4 times. But I think the highest protein, let me actually yeah, like in the 40s.
Okay.
The ones on that chart are all very normal.
Yeah.
But notice that the pleocytosis that everybody, including Rana, was talking about, and Jen, is persistent. And again, I don't know that 54 or 55 is low, but you've got to have a serum glucose.
Yep. Yep.
If she's 16, and she's probably not got metabolic syndrome like the half the patients that are receiving hospital. But 54 is, quote, that's why the whole idea of normal, like saying a normal CSF IgG without knowing the serum IgG, it has no meaning.
Right. No, I was thinking that Milo was going to be salivating about vasculitis. Let's go after it, but I'm.
If the lab says it's under 30 or under 10, wherever their cutoff is, okay, you don't need the blood unless the patient's hypoglycemic. But we've seen that once. But 55, if her blood sugar was 150, that's not so normal.
That's right.
So her repeat LP at this point showed continued elevation of her opening pressure, still pleocytosis, and this time we did send for oligoclonal bands. She didn't have any, and she had a normal IgG index as well. We sent the Mayo Pediatric Autoimmune CNS panel, both the CSF and serum, and the serum one included MOG IgG, and both her panels were negative. So at this time, because of the enhancing lesions, the pleocytosis, we treated her empirically with high-dose salumedrol, and then started her on a 6-week oral prednisone taper. Her diamond.
Sorry to interrupt. Did you guys look for malignancy, like a CT scan of the chest, abdomen, or pelvis, or PET scan?
We ended up doing that like later, and at this time, I think we just did a chest X-ray, which was negative. But later on, we did do CT of chest, abdomen, pelvis, and was negative.
And again, the CT of the chest or PET would also be good for sarcoid.
You bet.
I'm sorry, what was that?
For sarcoid.
CT of the chest.
Yeah, exactly. Yeah.
It's also, the latter is the most sensitive, but a lot of them are picked up, hyaluradenopathy, just on a plain CT. It doesn't make it the definite explanation, but now you have at least possible, if not definitely probable or definite sarcoid. But, a lot of things are in and same thing with when you can't get them to pay for a PET.
And for the trainees, a normal ACE is present in 50% of those with later confirmed neurosarcoid. So a negative ACE should not stop you. You want to go to the next level, and that may be whether it's inside or gallium or whatever.
Microglia and monocytes make ACE. Okay, finding an elevation doesn't prove anything. And again, although I've had arguments with Barney Stern about this, if you measure and you've done both serum and CSF ACE, but again, it's hard to interpret it as CSF ACE that's mildly elevated unless you know that what the patient's ACE was in the serum. And you almost need, I've argued, an ACE index, like an IgG index, comparing it with albumin, although it's not widely done. And Barney says, well, they don't usually do that. But thinking about it, at least theoretically, that's what you ought to do.
Yeah.
Well, as you say,
So
Barney Stern
Dr.
and
Lisa.
Carlos Pardo, both at Hopkins, say don't do the ACE anymore. It's a worthless test.
We didn't hear what you just said. What'd you just say, Scott?
I was going to say Barney Stern and Carlos Pardo, who are the two neurosarcoid experts at Hopkins, they beat it out of us not to order ACE any longer because the sensitivity and specificity are just not there. And you have to look at the clinical syndrome and then also the imaging, as what was said earlier, to really confirm a diagnosis outside of the biopsy, which is most important.
If we ever do another version, Scott, of that international neurology, I'm going to have Barney revise that chapter because
yes.
Jeff Cohn did a study, I think, when he first got to Cleveland Clinics about doing ACE levels on serum and spinal. I don't know if they did spinal fluid, but it was as to rule out sarcoid in MS workups, and it was totally useless.
Well,
have you guys had better luck with the serum soluble IL-2 receptor? It supposedly has a higher sensitivity than ACE, but I haven't had a lot.
They're all inflammatory markers. Okay, so if everything else fits, that would support it. But IL-2 and IL-2 receptor are driven up by cytokines, and monocyte macrophages. That's who's making it in sarcoid, but that's who's making it in other things. And in the brain, if you have monocytes in the meninges from anything, it might go up. And microglia within the brain, being monocytes, when we see increased ACE receptor levels in our tissue cultures that have microglia in it, we've never chased it down, but I'd be willing to bet that's where the gene is elevated.
Yeah. And there's no substitution for a complete exam, laying hands on skin, intertriginous zones, adenopathy, looking for things and places that are conspicuous and not normal that might give you the opportunity to actually get the tissue diagnosis. Even though most of the play may be central and other places, it may be systemic. And I've been spanked numerous times, and a big workup, we were suspicious, and it was there. It was there for our exam, but you had to be awake and, have a pulse and breathing. And this is where I give the discussion to the residents.
And in here, they did look for the IL-2 receptor for however specific that might be, and that was normal also. So
yeah, right.
So Maria, it looks like you have a lot of negative tests here, and then you sent off for whole exome. Any other comments you want to make on this, and then take us to what happened next?
Yeah. So really, all of our workup at that time was negative, including some of the metabolic workup, very long chain fatty acids, and CSF lactate, plasma amino acids, urine organic acids, and then the HER-HO exome is still in process. So she did really well, actually, on the steroid taper. Her headache was gone for the following 3 weeks. And then her ophthalmology exam 4 weeks into her steroid taper showed normal vision, visual acuity, and improved edema in her optic discs, now just at trace. She continued to have visual field scotoma in the left that was worse on the right. And then her OCTs at that time was increased bilaterally, the RNFL, but there was no number reported for this exam. During her 5th week of her steroid taper, she was on about prednisone 20 milligrams daily. Her headaches returned and worsened to the point where she went back to the ER. We repeated MRI at that time, and it was stable, no enhancement this time. Her LP was repeated 3rd time, and this time she actually had a normal opening pressure, normal cell count, and protein glucose. And really, we didn't really know like what to do, so we kind of just restarted her oral prednisone taper because she was doing really well, like symptomatically, hoping that she just needed some more time before this process resolves. And she was also treated with other symptomatic stuff for her headache, including occipital nerve block, and she was started on Topamax.
Maria, I noticed on your formal exam here, you're measuring a scotoma. I'm assuming central scotoma. And on your exam before, did she have a central scotoma, or did she just have those?
She had it since May, basically, before her first eye exam. That was what prompted her to finally go to the eye doctor. Yeah, so she's had it kind of this whole time.
Inconsistent with just elevated intracranial pressure. Okay.
Yeah. And what were those extending into the blind spot? I mean, would you have characterized those as secocentral, or were they basically islands out there in the central field, not associated with the blind spot?
Yeah, I'm not sure. Yeah, and I think that later on they did formal visual field testing, and they weren't ever able to really pick it up on the formal visual fields. It's just that she was like reporting that it was there.
Okay.
Great.
All right.
Okay, so I feel like.
Wondering why the slide has gotten so small again, but maybe that's just me.
Okay, so she was restarted on this 8-week prednisone taper, and again she did very well. She her headaches were well controlled. She was attending virtual school full day, full time, and then her follow-up ophthalmology exam now 2 months later in November again showed trace edema bilaterally, which was stable. Now her visual field on formal testing was normal except for the small area, now just in her left eye, not in her right anymore. Her OCT showed actually a reduction over the past 2 months, and the numbers for the RNFL this time was 121 and 123. And unfortunately,
what were they prior to that? I mean, were they really
it was
elevated?
not reported. It just said it was increased bilaterally.
I see. And
Yeah.
GCL, IPL, you get it in there, but you're basically following the RNFL on this one. But yeah, it'd be interesting to see what the GCL, IPL look like, given that the RNFL is subject to water effects, right? Whereas the deeper compartment, much less so.
Yeah, wait, so what is the GCL and IPL?
Oh, the ganglion cell layer, interplexiform layer, very reliable in terms of retest variability, less subject to edema, fluid accumulation in the layers that you can see in acute and subacute optic neuritis. That was my only point. And problem is, you have somebody coming in and they got 130 or 140 in one eye and the other eye may be close or not. You don't know what it was before. They didn't call you 3 days and say, let's do my baseline now, because in 3 days I'm going to be puffed up and I'm going to have inner retinal edema at the RNFL. So where does it settle out to the point where you say, now I can count the regression, for example, of fiber loss in the RNFL, which is 80% axons, 20% glia. So the GCL IPL is a bit more reliable. And look, I got to be careful because I've got the G-man on, the God-man, and I've got Balser on, and then I've got Jen on. So the question is, if we update, do we still feel that it's useful to have it from the standpoint of the RNFL, but its utility is difficult if you don't know where it was before and you don't have serial measurements to see how soft the landing is. The GCL IPL, Laura's and Peter and Shiv and all the work we did on this suggested this was the more stable compartment, particularly acutely where water can be a confounder. That's the only point.
But if you were following actually just I guess the optic swelling from edema, would you be using RNFL to?
You can definitely do that.
I would at all.
And there's also an optic nerve head volume protocol that some of us are using. Maybe some people still feel that protocol is controversial. There's even more advanced OCT work going on by several people here and several colleagues looking at really nice new metrics for following it. But if you just have a routine OCT setup, collaborating with your ophthalmologist, you can definitely follow RNFL at the extremes. 2 micron difference isn't gonna get you excited, but at large extremes it can be helpful. It's really helpful to show patients. They can see those pictures and follow those numbers. But there's also an optic nerve head volume protocol and some other exotic things that.
And Maria, old techniques, which time domain OCT, we had a retest variability as much as 8 to 10 microns. And if you've got 3/4 of people, just say MS, of optic neuritis, within 3 to 6 months, will lose between 10 and 40 microns in the RNFL. To be conservative, you'll take the 10, but you sink your ship in shallow water because to do a neuroprotection study, whatever it is, you got to be really down there. So spectral domain took over time domain, which then brought us to a sensitivity resolution of about a micron. So, when Jen was saying, I'm not excited with 2, but by the time we're at 4 to 8 or 10, and it's correspondence with, Laura Balser's, low contrast letter acuity, now you're in business. Now you can measure it.
But we have to say that for the purpose of elevated intracranial pressure, what some of those correlations are with vision is probably a little different than what the very precise work with optic neuropathy. And then also go back to Maria's question about what do we do with the GCL, and if now in this case we've got some red flags. This isn't all intracranial pressure if we've got a central scotoma, but if it's a real central scotoma, but I think it's a little less clear what to do with the GCIPL in elevated pressure.
Right. Yeah, so the tough thing, according to, I've talked to Rachel Penny, our graduate student, and others. Sorry, my connection's a little slow here, but anyway,
that's great.
I think that basically you want to be able to place the lines where they belong, and that aspect is critical for optic disc swelling in this population. So you may get something back that says, oh yeah, this person's RNFL thickness peripapillary wise is 282. And you're like, whoa, is that accurate?
Whoa.
And so, right. So you need somebody to really draw those lines in the right spot, as our techs and Rachel have pointed out. So that's something to keep in mind.
And for the fellows who haven't had to run an OCT protocol, I think what you mean by placing those lines is that there is some either arbitrariness if you're doing it manually, or there sometimes can be some issues with software that automatically tries to calculate the boundaries of the different retinal layers. So I think what we're saying, Maria, is that there's some key technical aspects to making sure we get accurate measurements of the optic disc swelling, particularly if it's subtle, as opposed to if it's just so obvious on the OCT. Just because of time, I think it looks like you've got a second ophthalmology finding on this slide, and I want to ask folks to reassess their differential with this key
Jen,
data.
can I just ask you a quick question? Sorry to interject, because some people may not know what RNFL and GCIPL actually are structurally. So I don't know if you want to tell us real quick what they are, what they're measuring, I guess.
I don't know if you're asking Maria or me, but the retinal nerve fiber layer are the axons of the retinal ganglion cells that form the optic nerve. And we can measure those axons as they feed back from the 360 degrees of the retina to form the optic nerve. And then what was brought up about the GCL, that's the cell body layer, the cell body connected to those axons that form the optic nerve. And we can make measurements with OCT of both the axonal layer and the cellular layer.
Yeah, I was asking you, Jen.
Okay.
And it's the unmyelinated axons.
An unmyelinated axon.
Yeah, that's a
thank
key
you.
to that. Yeah.
Doris is still on the line, right? So what I will do is I'm going to send a couple of papers that review this all for the fellows. But before I do, I'll send it to Jen and Scott and Laura and Steve and say, are these reviews that you like, particularly for the fellows? And we can pick and choose or something else. But I'll take the initiative of that after the call so they have it. So that's a good read. I think it's important.
Hey, Maria, so what happened in December?
Yeah, so her headaches essentially worsened basically as soon as her prednisone taper finished, and her follow-up exam about 6 weeks later showed trace edema again, but bilateral anterior uveitis, which is new for her, with 1+ cells, as well as precipitates on the cornea, and the ophthalmologist did say that it was the type of KP was not considered to be granulomatous. So at this point, with the uveitis and the rest of her clinical picture, what would the modified differential be?
Well, let's quickly start with a few fellows. Now we've got anterior uveitis. What do you want to throw out on the differential? Okay. Maybe Sarah, Tyler, Netta.
Go big. Just start talking.
Interior
Categories of disease.
uveitis and the
Correct.
precipitates made me think of sarcoid. Move that higher up on my list. But then I was wondering how to interpret the next line on there that says it's not considered to be granulomatous.
She was on steroids for a while. Doesn't mean anything.
Okay.
Any other thoughts, Daniela, Taga?
So,
I think rheumatologic perhaps, or I would also potentially think of an infection.
Can't hear you.
Having a hard time hearing you, Daniela. I don't know if you're away from the microphone.
Yeah.
Can you hear me better now?
Yes.
A little
So
bit,
I was
yeah.
just saying that perhaps something rheumatologic or an infection is also should be considered.
And having been on steroids, the issue is could you unmask tuberculosis, syphilis, all the usual suspects? But checklist, fly-by protocol, you don't want to miss those, and they're treatable.
So how long? So she had been off of steroids by this point for about 6 weeks. How long would you expect the masking effect to continue for?
Yeah, that's difficult because, as you know, these are not like antagonists. Aspirin binds, pops off. These are obviously intracellular effects with steroids, which can be quite long-lasting. So my short answer in this particular case would be, I don't know. Longer answer is, as you actually have a longer latency from cessation of steroids out, you'd imagine that it would settle down. However, if you unmasked a cold TB or another, an indolent infection, I would say it's just getting going, because now it potentially mechanistically has the upper hand and is no longer in check because of immune regulation. So that's a great question, but I don't have a great answer. Anybody else?
No, I think you're right. The other thing I was thinking about is more of a steroid dependency type nature here, where you're weaning someone off of steroids and their underlying immune disorder, if this is what it is sort of coming back, even though there's this disconnect between the imaging and the ophthalmological evaluation. But we certainly can see that delay. And so I would think of it maybe more in the context of a steroid dependency, which I do think can help sort of whittle down the list. And I'm sure you're going to have some things on your modified differential that fall under that. I'll just make one last point and ask the fellows, what about the initial presentation with maybe a meningeal process? Here now you have an anterior uveitis, and there's a sort of rare condition that I think was mentioned earlier that can fall under this bucket that does have some steroid responsiveness early on, and will eventually require immunosuppression.
We just missed what you said, Scott. Can you repeat that last 10 seconds?
Which part?
Just the last 10 seconds. You were going into steroid responsiveness, and I wasn't sure if you were talking about Voikoya Nagihara.
Yes, correct.
I just didn't hear it come out of your mouth. I wasn't sure.
Oh, no, I was trying to put it out there for the fellows, but Dr. Froman, you can answer it too.
No. I didn't hear it. So I just,
Yeah, no, it was, when you have someone that presents with a meningitis-like picture initially, and it's recurrent, and then following that, you end up having a uveitis, especially anterior, although it could be panuveitis, you have to start thinking about VKH. There's a whole other systemic manifestation to it, but the cases that I've seen, which are very few, this is sort of the typical presentation, and they're very steroid dependent, and then you have to go on to immune suppression.
What do you think about the MR imaging for VKH, Scott?
Yeah, that's the only thing that's throwing me for a loop. The cases that I've seen have had some white matter lesions, but they've been more discrete and not so confluent. But again, rare diseases, you have to sort of be willing to be open-minded about what's the full spectrum of involvement.
How about the poliosis that is associated with VKH? Did we hear anything about that? And I'm not sure how early is that.
Yeah, we had asked about it early, but Maria said there was no evidence. Make sure we recognize it's not just the forelock. It can be the eyelashes, right? It's not just the hair. And some people think it's really great. It's very cool. I'd like to have enough hair to have a poliosis, but some of these guys, they'll camouflage, they'll color their hair. But if not,
the
you got to look for that.
The ones I've seen have all had eyelid problem, but that's not a lot.
I'm sorry, what was that? Was that Bob?
The ones I've seen have all had eyelid involvement, but I haven't seen a slew of patients. It's rare. And,
So just watching the time, and I think she has a few more slides. Maria, do you want to show us where you guys went from there?
Yeah, so this was our kind of modified differential. Statistically speaking, if you have uveitis and white matter abnormalities, the uveitis specialists say that you're most likely to have MS, but clearly she does not have MS. MOG, she's been tested 3 times, but MOG has also been reported to be associated with uveitis as well. So then in an inflammatory autoimmune category, we definitely thought about sarcoid. She would, her CT ended up being negative for any hilar lymphadenopathy. So she would fall under possible sarcoid or possible neurosarcoid. And then VKH, again, basically what you guys have already said. She didn't have any skin or like alopecia or the hair changes, but I'm not sure about, I guess, the eyelashes. I can look into that. And again, the white matter abnormalities I've seen for VKH in the literature are all kind of more discrete, like smaller lesions. Neurobruchettes. She's never had oral or genital ulcers, but it possibly could be a developing Behçet's. And then some other kind of systemic rheumatologic diseases, which she, didn't really have any other rash or joint symptoms or muscle aches or dry eyes or really anything. And then infectious, we did end up doing quantiferon gold on her, and it was negative off after she's been off steroids for about 8 weeks at that time. But we thought that it was just less likely. Now it's been going on for a pretty long time, 8 months now. And she didn't really have any other kind of symptoms of infection. And then neoplastic, which she hasn't had significant changes in her brain lesions, and her CSF cytology was negative, and she had that body CT as well.
Yeah.
So,
I think
just
one other
a
thing.
quick,
Sorry, go ahead. Sorry.
you need to eliminate the use of the term Wegener's. We don't use it anymore. Dr. Wegener had some interesting experiments he did on unwilling participants during World War II.
Yep. Yep.
Thank you.
I'll just make a comment about the uveitis. You had mentioned MS. So typically it's an intermediate uveitis. So if you see anterior or pan uveitis, it's not MS. I mean, I'll defer to Jen and others who,
Absolutely, yeah.
are in that world, but I would say that's it's typically intermediate. And that's where, really reaching out to our retinal colleagues, if they've seen them, and pinning them down to what type of uveitis it is critical. Because I've seen a couple patients over the years where that information was not available, and it became tricky in some instances.
And Scott, the fact that we're always pushing in a loving way for our trainees to carry their ophthalmoscope, to actually make sure it's charged, know how to turn it on. The issue with a lot of this is the uveitis, the lesions, even when we're talking about, branch retinal artery occlusions or gas plaques, if we're talking about Susaks, or we're talking about peripheral retina, neurologists in general, we don't do as well. If we're getting on the disc, we're doing pretty well, but you said it best. This is where we consult our colleagues. We get retinal photography. It's not invasive. And you can sit and look at this as long as you like. And sometimes it does take some extra time to ask, what am I looking at? So getting photography and OCT, I think, would be critical as a benchmark and going forward. The two other things I would raise is, if this was a patient with this story and had like bone pain, for example, maybe you're thinking really outside the box, something like, Erdheim-Chester. Or you have somebody who has, very focal brainstem, and they open their mouth and they have a palatal tremor. Then you're thinking, is this Alexander's disease? This is like what Scott and Jen, from the time they took over in September, have recurrently underscored the point. Because you have a low B12 or folate, this or that, that doesn't mean you stop when this is a new kind of B12 deficiency. It's called not B12 deficiency. They have B12, but it's a bigger syndrome. You got to keep going to get the full answer. And we've had some beautiful examples of exactly fellows doing that, which have become invited papers. So you got to keep going.
Okay, I think, Maria, if you want to, we want to maybe have a few more comments from faculty in a moment, but you want to just take us, I think you have 2 more slides, 3 more slides.
Yeah, and then we ended up repeating her LP a 3rd time, or actually a 4th by now. And again, she had elevated opening pressure. This is off steroids, pleocytosis, her oligotonal band and autoimmune panel were repeated, again negative. Her brain MRI showed no significant change compared to August, no enhancement. So by the time that the actual uveitis specialist saw her, we had reinitiated high-dose steroids because her headaches were becoming unbearable. And she was already on a taper of prednisone. She was also getting prednisone drops to her eyes. So her eye exam actually was actually normal, other than the trace edema. So they weren't able to really characterize her uveitis as well as we would have hoped, because initially it was just picked up by the general ophthalmologist. But regardless, now this is her third course of prednisone. We really did not want to continue prednisone long term, so we made the decision in conjunction with the uveitis person to start methotrexate as a steroid-sparing agent, kind of for empiric coverage of this inflammatory autoimmune category.
Let me just add one thing because it's treatable, and living in the world we're living in, this is a very complicated case. But the other issue would be to flag PCR for Whipple's disease, which used to be jejunal GI tract, become a very different demographic because of the way we use antibiotics. I'm sure you know this, but these are treatable issues, and before you get the complicated eye movements or triads or oculomasticatory myarrhythmia, I'd say it might be a good idea just to look at that. It's treatable.
Mm-hmm.
And I guarantee you, if I didn't bring it up, Galetta would have sent me a message after this and give me a spanking and would say, hey, Elliot, I'm disappointed in you.
Never, never, never.
Well, I try not to be. That's why, you got progeny on this call. Jen, me, Laura, come on.
It's like
No,
I
we have to get through this, but my mentor used to say about VKH, too bad you got Pruvad. And P for poliosis, U for uveitis, V for vitiligo, A for alopecia, D for deafness. So that's how I remembered it all these years. Too bad you got Pruvad. Anyway.
No, you gave it to us. That's why I couldn't let it go without bringing it up. But keep going, Maria. You're outstanding.
Yeah. So this is it. I mean, we briefly talked about if she fails methotrexate, we could consider something like mycophenolate. I don't know.
So Maria, would you like, because this is a little different case in the sense that you guys haven't gotten to a definitive diagnosis and you're kind of facing continued immunosuppression with this constellation. I'd be kind of curious maybe to run down the faculty and fellows to see if people want to volunteer either if they think a diagnosis is or a test is that you might want to consider in addition to weighing in on other immunosuppressants. Does anybody, faculty or fellows, want to just say really briefly whether you think the diagnosis is or a
Jen,
test?
this is Rana. I will actually continue to monitor her for the possibility of something autoimmune or like tissue diagnosis, basically CT scan from time to time or a PET scan.
Totally
to see if I can take any tissue and analyze it.
That if anybody would biopsy, yeah, okay.
I didn't catch the background in terms of race or ethnicity. Is there any?
She's Caucasian.
Okay, just because VKH, there's certain subgroups of people. My vote is still for, I think, VKH, just given the clinical presentation.
That's a diagnosis of exclusion, right? Like there's no rate, like one test or like any test. Yeah.
Hey, Maria, a definitive diagnosis of multiple sclerosis, at least in our center, my wife and I, we always refer to it as the working diagnosis in case data becomes available where it no longer works. So we avoid things like 100% or, incontrovertible, definite. It's a working diagnosis, which gives me an out. Some patients laugh at me, but at the end of the day, I ask them, do you want me to be right? Or do you want to ensure that we get it right? The answer is pretty obvious. And I liked your idea about using agents that cover multiple disorders. You said that multiple times, including almost at the very inception of your talk. I think that's very important.
Yeah.
What I guess what makes you think VKH is more likely than neurosarcoid?
Yeah, so I mean, I think neurosarcoid, at least the cases that I've seen, it certainly can behave where you have this meningitis picture followed by uveitis. I think the uveitis that often occurs in the setting of granulomatous disease is not so localized to the anterior, if that was correct. If it was correct. But again, I think you may never find out, and I think the proposed treatment seems reasonable. I personally would have gone for CellCept first, but that may just be a educational bias on where I am. So interesting to hear why methotrexate was brought up.
Yeah, we I think if it was completely up to us as neurology, we would have done CellCept or azathioprine, but the uveitis specialist was more comfortable using methotrexate, so we just decided it was like a preference.
And in the pandemic, this WHO essential medicine, methotrexate that you're speaking about, is so attractive because of the diversity of different mechanisms, including inhibiting viral replication, folate inhibition. We've got the RAGE receptor stabilizing granules to reduce cytokine release syndrome. So Doris, I'll send you that other paper. It's part one of the two-part series we published last year, which specifically goes through almost like a wheel of fortune, the various mechanisms by which methotrexate works. By the way, notwithstanding that, I agree with Scott in this case. I probably would have started, because of the experience of so many patients, I would have started mycophenolate mofetil.
But she's young, right?
Yes.
I would be cautious with methotrexate and potentially would be more comfortable with something like azathioprine, where you can still continue during pregnancy. Methotrexate is problematic.
Yeah.
And
why I like CellCept for that reason.
Mycophenolate is very problematic with pregnancy.
Okay. Well, that was a fantastic discussion. Do we have any other final 10-second diagnoses or more votes to do biopsy versus empiric therapy? Otherwise, we'll wrap here.
I have something quickly. One diagnosis which is unusual, but probably not the case. It's actually aseptic meningitis in relation to NSAID. Somebody with chronic history of headache, she's taking the medication all the time and she's having some aseptic meningitis. Although the case I have seen, the number of white blood cell is way higher than that. And then the other one is, I would not have felt comfortable treating her with immunosuppressant because I'm more of the idea, no meat, no treat. But maybe sometimes.
What about like the repeated courses of steroids?
She was so steroid responsive.
Yes, I understand, and maybe I'll
recovery is much harder than prevention. There's risk all across the spectrum. I agree. This is where we have heterogeneity. Maria, you're going to have to decide what you think, because if you're asking what's the correct, you could ask Galetta, and I would ask Galetta too. But which are you more afraid of? The therapy in a patient like this, or the fact that it's going to continue, or its slope may change trajectory, become more severe and more deficits? And I certainly had that on my watch, and those are the most salient cases, the ones where I felt I blew it or I went light at a time when I had an opportunity to kibosh it.
One other thing, it was way over, but Rana's point, and she's implied that along the way, is in this case, Maria, and in any other case like this, the key thing is not to decide that you know what they have. So every time something becomes different or flares or periodically, you just got to rethink. And sometimes go back to, repeat that CT, do the PET CT, gallium scan, whatever, especially if they do something that's not expected. I think it was a Fred Plum line, Steve, about never fall in love with your own diagnosis.
Bingo. That is really great. And great comment.
Thanks everybody for a great discussion. Maria, keep us updated on what happens. Everybody have a good night, good week.
Doris, I'll send you the numbers, and thanks, Laura everyone. And Steve, so grateful when you guys show up, and we just love you, and it adds so much. So thanks I know that's late, it's busy, but thanks for getting on.
Nice to see everybody. Take care.
Bye everyone. Thank you.
Scott, thanks Jen. You guys are awesome.
Thanks y'all.